Hi there, and welcome to this 1-hour CEU webinar on colorectal surgery, anatomy, physiology, and CPT coding challenges. Also sneak in some pathophysiology and a little bit of diagnosis coding as well. I'd like to make reference to these resources that I've used in the preparation of this webinar. I highly recommend you acquire these. At least whip out your CPT manual or fire up your encoder. And feel free to pause this webinar at any time if you need to dig in a little bit deeper or find a certain category of codes that we're referring to in the presentation. This presentation is worth 1 hour of CEU credit through AHIMA or AAPC, and you earn that credit by taking a post-test of 10 questions. You get 2 chances to make 80% on that test, and you take that right after you see the presentation here, and you'll get your CEU certificate issued right then and there. You can download it and save it or print it out as you need to. And this CEU is valid, or this course is valid for CEU from May 1st, 2018 for a year after that. The learning objectives as required by AAPC and AHIMA you see on the screen before you. I won't read through those individually except to say that this is just meant to be sort of a primer on colorectal surgery, some of the challenges you might encounter, a bit of a lesson in anatomy and physiology so you can best conceptualize CPT procedures as they're being done so you can correctly choose the codes, and look into some of the pathophysiology so you can understand the underlying problems that lead to the types of surgeries that you may be coding. My name is Ed O'Byrne, and I'm a physician assistant formerly and currently a coder, and I enjoy auditing and consulting and educating coders in particular. I'm the Director of Revenue Integrity for Healthcare Resource Group. You're always welcome to give me a shout, and my email address is at the end of this presentation. So the agenda, as far as what we're going to go over in this presentation, you'll see there. First we'll look at colorectal anatomy. It's not super complicated, but it can't hurt to review that before we dive into the pathophysiology. So there's a few of the conditions you can see there that we'll be exploring and the treatments for them. So fistulas, abscesses, hemorrhoids, polyps, inflammatory bowel disease, cancer, and a couple of more unusual ones which I think are interesting when you see one on a record, and also kind of help to understand the anatomy and physiology of the colon itself. Volvulus and Intussusception, which is just a fun word to say too. And then we'll look into a couple of the categories of procedures that we're likely to code or might be called upon to code, and from endoscopies right up into total resections and replumbing the colorectal system so it continues to work, including pouches. Here's that familiar picture we've all seen a million times of the entire digestive tract. And just to emphasize, we're looking at the latter portion of the alimentary tract. The alimentary tract is where the food goes, so to speak, and that's the colon and the rectum. And a little bit, not labeled here, but the ileum, because it is what's plugged into the colon. Now the colon and rectum were formerly the purview of proctology, when we call that colorectal surgery now. And colorectal surgeons are, as far as I know, all general surgeons first. And there's still plenty of overlap between the surgeons that take care of the colon and rectum and the rest of the alimentary tract, including the stomach and small intestine. But we'll focus on just the colon and rectum for this particular presentation. So the colon physiology, what the heck does it do? Mainly involved in water absorption from the already digested and nutrient absorbed chyme, it's called CHYME, that passes through the small intestine and then is dumped through the ileocecal valve into the colon. Water is a precious resource in the natural world, and so to reabsorb it is advantageous to us as organisms. Some animals use the colon to absorb nearly all of the water. Rodents in particular are notorious for having very dry stool because they recycle all of that water. There's also plenty of bacteria, which I'll revisit in a second. But those bacteria are responsible for fermenting some of the residual nutrients in that chyme for additional nutrient resorption, but also those bacteria produce certain vitamins like vitamin K, vitamin B in the colon, and then it's absorbed and used by the rest of our bodies. Now that collection of bacteria is called the microbiome, and it's become more and more recognized as a vital part of our existence, some people even calling it its own organ. It's comprised of about 100 trillion bacteria, which is pretty amazing, especially when you consider that there are about 37 trillion cells in the human body. So tallied up, actually the bacteria outnumber our own cells in our body. So that's just a fun little factoid you can share at your next cocktail party, right? Press your friends. The anatomy of the colorectal system here is, again, pretty simple, but let's review that. This is important to note for certain diagnosis codes, definitely for PCS codes, which I won't get into in this presentation, Not as much CPT, but it can help you understand a few of the coding scenarios. So let's go over it quickly. So remember, small intestine terminates in the ileum through the ileocecal valve. The cecum is this sac-like structure at the beginning of the colon, and it is intraperitoneal. Just kind of put a pin in that concept, and we'll revisit in a second. Then the colon goes retroperitoneal behind the peritoneum in the ascending colon. Ignore the tinea; those are just the markings along the three sides of the colon. The hepatic flexure, referencing the liver, hepatic, as the liver hangs out right kind of behind and adjacent to the hepatic flexure. The transverse colon is intraperitoneal. It is not tethered. And then the splenic flexure, at that point, the colon goes behind the peritoneum in the descending colon. Finally, the sigmoid doesn't get good justice in this illustration. It's typically more S-shaped, hence sigmoid, and then through the rectum and anus. And I should preface by saying, like most of my presentations, I'll use plenty of illustrations, all in good taste. In fact, colorectal medicine is reputed to be one of the cleaner types of surgery because the patients are all prepped. So don't be too frightened, but there are a couple of surgical images coming up. So let's dig into that intraperitoneal, retroperitoneal issue a little bit. And this is frankly more of an anatomy lesson. It doesn't have too many implications in coding, but it's an important part to note, and it's a little bit hard to understand. Looking on the sagittal section on the left, you'll see that peritoneum is represented by this pink shading, rather the peritoneal cavity. And the lining of that is the peritoneum. It covers all the wall of the inside of your abdominal cavity. But it has a fold in it called the mesentery and the omentum. So the peritoneum comes out and invests, so to speak, the transverse colon. You're seeing that cut in the center, and then out into the omentum. And don't worry, I'll show you a better picture in just a minute. Comes back, invests the stomach, and then rejoins itself back here behind the liver and continues on around. So there's this fold inside the peritoneum that's made of peritoneum. It just performs different functions, namely it being mesentery and omentum. Seen in a transverse cross-section, you'll see the peritoneal lining around the peritoneal cavity here. And look here, what's behind that peritoneal membrane is the descending colon on the left. And this is like if you look down on yourself. So this is left and this is right. And the ascending colon coming up behind the peritoneum on the right. So those two, the ascending and descending colon, are anchored in place. Can't twist, hard to get obstructed. So as far as the relationship to the peritoneum, different structures. So at the intraperitoneal location of organs is really most of them. The liver, the stomach, not the kidneys, the reproductive organs, spleen, and namely the cecum, the transverse colon, and the sigmoid colon are all intraperitoneal. So they're free to kind of move around in relation to the surrounding structures to some extent. What's retroperitoneal are the kidneys, not depicted here, but also the ascending colon and the descending colon too. So everything between these two yellow lines here and between these two yellow lines here is retroperitoneal. So here's that same picture again, just shaded a little differently. Descending, ascending colon there. Okay, so why is that important? It's for a certain particular pathophysiology that can occur with the colon. The mesentery is that specialized fold of peritoneum that comes in and grabs onto not only the large intestine, the colon, but also the small intestine has its own mesentery. Now, more correctly, the mesentery of the colon is called the mesocolon, and even the appendix has its own little bit of mesentery called the mesoappendix. What that does is a few things. One is it anchors the colon in place, the parts that are not retroperitoneal. It just kind of keeps it up tight against the, against the rest of the organs. And that's kind of an arbitrary function, but that's one thing that it does do. It's also the vascular supply for the colon in this instance. It provides the arterial supply and the venous drainage through the mesentery. And there are also lymphatics, lymph nodes and lymph vessels, which is important to note in cases of malignancies, for example. The first place they usually travel is the lymphatics. So you'll often see reference to mesenteric lymphatics as a point of excision for the likes of biopsies. And then finally, another specialized fold of the peritoneum is the omentum. So this originates from the rear of the peritoneal cavity and comes forward, invests or goes around the stomach and then around the transverse colon and forms something of an apron, as you see this diagram on the right, it's not anatomically that pretty, but it does kind of depict hanging off the stomach with the transverse colon inside it and coming down and covering all the rest of the abdominal contents. Here's a surgical image of it lifted up, and you can see the transverse colon here, and the inner omentum, the lesser omentum, and the greater omentum here that would hang down. It's full of, you can see, visceral fat. This is the fat that gives guys like me a little bit of a gut, even though I don't have too much abdominal wall fat. It's the inside stuff. Supposedly that's the more dangerous type of fat, is visceral fat. But it has a couple of really interesting functions, surgically speaking. It's full of stem cells, which, as you know, can differentiate into just about any other type of cell in the body. So they're great for healing any other organ that the omentum may come in contact. And because it does that in a natural sense, it's been used by surgeons to intentionally treat inflammatory and injurious conditions in the peritoneal cavity, and is therefore called the watchdog or the dog. And it's not uncommon to use a little bit of omentum to tuck around an abscess cavity or an excision or a reanastomosis, because it'll kind of guard that area against infection, and it'll use those stem cells to promote healing. So it's kind of interesting use of the otherwise pretty obscure organ. That's the omentum. The vascular supply of the colon, and arterial-wise, we're looking at the superior mesenteric artery here and the inferior mesenteric artery here. And the colon has a very clever collateral arterial circulation in the form of the marginal artery. You can see it runs all the way around along the edge of the colon. And both the superior and the inferior mesenteric artery both feed into that marginal artery, so that if there's occlusions of any one of these branches, or even theoretically of the main mesenteric artery trunk, superior or inferior, the rest of the colon will still get arterial blood supply. So it's not super common for colonic arterial infarct, but when it does happen, it tends to happen kind of at the junction of the inferior and superior mesenteric artery watersheds. Notice that the rectum also receives blood from the inferior mesenteric artery, but also directly from the branches of the iliac artery in the forms of the rectal arteries here. That is sort of an arbitrary distinction, doesn't have a lot of clinical relevance. Conversely, the venous return supply from the colorectal system is kind of interesting. Now, just like the stomach, the duodenum, jejunum, ileum, the colon returns its blood through the hepatic portal vein here, which goes through the liver. So everything absorbed through the gastrointestinal tract, with an exception I'll show you in just a moment, goes through the liver first. So pharmacologically speaking, subject to first pass metabolism. So drug dosages given by the GI tract have to be adjusted for the fact that the liver is going to remove some of that drug. The one exception is this, and that's the rectum. So medicines given in the form of a suppository are absorbed by the rectal venous plexus, which drains directly into the iliac vein and into the inferior vena cava, which then goes directly to the heart, back out into the systemic circulation. So there's no first pass metabolism through the liver. So an otherwise completely, I think, irrelevant form of administering medications through the rectum, turns out it actually has some advantages, despite its obvious disadvantages too. But that is why, right there, no first pass metabolism. And then finally, the sphincters for continence, pretty handy development. There are two main anal sphincters, the internal and external, and these do not refer to inside and outside the body, but rather the concentric organization of like a donut inside a donut. And the internal anal sphincter you see here in cross-section extends a little bit further up into the anal canal and the rectum, and it is involuntary. So it is constantly in a slight degree of contraction, so it holds everything in. The external anal sphincter, as you see here and here in cross-section, it's voluntary and involuntary. So it has some voluntary functions, and as it begins to stretch, it stimulates receptors, perception in our brains, that we can voluntarily close that up. Ignore the hemorrhoid illustration here. I have better stuff coming up. And so here we'll start with our first disorder or pathophysiology, intussusception. I promised I'd start with kind of a weird one for you. And if you've seen one of these, you'll never forget it. And probably if you coded one, you'll never forget it too. Intussusception occurs when a part of a tubular body part, and it's usually the colon, it can occur in the small intestine, telescopes inside itself. Now this commonly occurs at the transverse colon or at the sigmoid or the cecum when it does occur, and it requires a lead point. So something for the colon in the current context of colorectal surgery to grab onto and pull it inside itself and treat its own self as if it was, let's say, food. So through peristalsis, this piece of colon is being pulled inside itself. Same here, this is telescoping inside right there. Usually pretty harmless if reversed quickly, but can result in ischemia and infarction, and it looks like this. Tissue is suffering some ischemia, and this may need to be resected out. Whereas this one's still healthy and pink, can be reduced just by pulling it apart. Commonly treated and preferably before surgery with a barium or air enema, which performs the same function just like a clown's balloon and just pops it apart, and the patient goes on about their business. Although that lead point in children is often a lymph node, in adults it can be a cancer. So that's the little chunk that the colon grabs onto and pulls it inside itself. That needs to be worked up. So intussusception. A volvulus occurs when an intraperitoneal part of the colon twists up upon itself. And if you remember, there are three parts: the cecum, the sigmoid, and the transverse colon. Now the transverse colon is fairly tethered at both ends, but the sigmoid and the cecum are sort of free to twist upon themselves. And here's what you'll see is a sigmoid volvulus here. So the sigmoid colon is twisted upon itself, and with it twisted its own mesentery that supplies arterial blood and venous drainage. So it's become incredibly edematous here. You can see that the transverse, probably and descending colon has become incredibly distended because it's obviously blocked right here. And although this is still pink, you'll see some, on this instance, this is clearly ischemic and probably infarcted. It's so dark, including the colon leading up to it right here. So volvulus can be pretty serious. And because it's a twisting function, you'll usually see, I hate to use the clown balloon metaphor again, but you'll see a loop here and a loop here pinched at one end and twisted at the other. And we call that a coffee bean sign on an x-ray. It's pretty hard to miss. If you ever see this on an x-ray, you'll know you're dealing with a volvulus. And this is treated with either by manual detwisting and then a resection or cutting out of that dead tissue, as you see on the right there, if that's what's needed. Now, jumping down to something much more common that most of us have coded for, hemorrhoids. Now, believe it or not, the name for these structures that line the anal canal are just hemorrhoids, believe it or not, or hemorrhoidal plexus, as we call them. What we think of as hemorrhoids are actually dilated hemorrhoidal plexus. But we'll just stick with the common concept of hemorrhoids as being, the kind that bother you and sometimes need to be treated. In any case, hemorrhoids are there for a number of reasons, one of which is they do contribute some degree of continence, which is to say that because they are located here and here, adjacent to the anal canal, and they're full of venous blood, any Valsalva type maneuver or bearing down of the core of the body has a tendency to push things out and tends to hold blood down and out in our periphery, including the hemorrhoidal plexus. So by distending out with blood, the hemorrhoidal plexi tend to close up the anal canal, along with, of course, the sphincters too. So they do something. The colon in cross-section is actually kind of like a clover. It's sort of three loops like that. And so the hemorrhoids occur similarly in a similar kind of symmetry on the left anterior, the right anterior, and the posterior. So it's a kind of an interesting case where there's not a symmetry of two structures on both sides of the body, but rather two and one in the midline. And that's where you'll see there's three possible hemorrhoidal columns or groupings. Now the superior hemorrhoidal plexus is here, and those, when distended, form internal hemorrhoids. The inferior hemorrhoidal plexus is down here, served by different veins, and when those are distended, form external hemorrhoids too. Now, usually the problematic hemorrhoids end up external to the body. Just be careful to note that it's their origin, not their kind of ultimate destination, that determines whether it's internal or external here. So you see an internal hemorrhoid and an external hemorrhoid here, served by slightly different venous plexi and with different locations of origin. Here's how we would diagnose hemorrhoids when given the stage. The kind we'll usually see is K64.9, not otherwise specified, but they come in 4 grades with different criteria or definitions, and I was surprised to see that this is a rare instance of ICD-10 actually has descriptions that could pass as actual criteria. I don't think I would ever see a physician saying these very things, but if they did, you could confidently code that, for example, a 3rd degree. Would have been nice, I think, if stage 1 had ended in a 1, 2 in a 2, they're just off by 1, 0, 1, 2, and 3. The stage 3 and 4 are the type that typically need attention. Diverticulosis and diverticulitis are, well, diverticulosis is super common in the Western world for many of the same reasons that hemorrhoids are, and that's diet and activity. K57 is kind of your general category, and there are a wide variety of choices of codes for these. This is not a bad excuse for you to open up your ICD-10-CM book. And what we need to know to code diverticulosis and diverticulitis are a few key elements. First, are they in the large or the small intestine? By and large, stumbled into that one, they're in the large intestine, and we are, after all, looking at colorectal surgery. But there are codes for in the small intestine as well. Whether they're bleeding or not, both the diverticulosis and the diverticulitis. And with the diverticulitis, whether there's perforation or abscess, and abscess. Now, with an abscess, it can be basically presumed that there's a perforation, and that's what let the bacteria out of the colon to form that abscess. The not otherwise specified, non-bleeding, non-perforated diverticulosis is K57.90. And here's what that might look like. Several outpouchings of the mucosal wall of the colon, commonly the descending colon and the sigmoid. And these are otherwise harmless unless they do perforate or bleed. They're rarely painful. And if an abscess does occur, usually an excision of that entire section of the colon is required. Just kind of depends on the circumstances. Now, one thing I'd like to caution you is coding colonoscopy is just a mention of a couple of diverticuli doesn't rise to the level of diverticulosis. That's a disease process too. So let the way the physician phrases it determine whether you treat it as a disorder, diverticulosis, or more like an exam finding too. So I like to predicate that on the presence of the term diverticulosis. As simple as that. Merely saying diverticuli, I don't think rises to the level of diverticulosis for a coding standpoint. For abscesses, they can occur around the colon in the instance of a diverticulitis with perforation, but more common spot we'll see is the perianal and perirectal abscesses. And there are several potential spaces, as we call them. That's areas between tissue layers which bacteria can collect and cause an infection. We see perianal or anal is K61.0 and on up the series of rectal, anorectal, which would be both, ischiorectal, which is behind the sphincters, and up adjacent to the ischium, which is part of the pelvic bone. Intersphincteric is between the internal and external anal sphincters here. Now, I was as guilty as anybody as an emergency medicine PA and a generalist, not being able to distinguish these very well. But again, we're hoping we're dealing with colorectal surgeons who have the skills and specificity to nail these down. But this is a point where a query might occasionally be necessary to determine which of these particular codes you're dealing with. I could imagine an intrasphincteric abscess just simply being called perianal, and if you're comfortable with that, slight loss in fidelity and specificity, that may be the best that we can do. But just basically know there are several different locations that abscesses can occur and require a little bit different approach for their treatment. Polyps are a big one on colonoscopies, and the significance is that some can turn into cancer and some virtually never turn into cancer too, and that creates a great fork in the road for us in diagnosis coding and also procedure coding for colonoscopies and polypectomies too. Clinically speaking, there are a couple of different types and then categories. Sessile versus pedunculated means if the polyp is laying flat against the wall of the colon, somewhat like these are, although they're starting to develop a stalk, might be considered sessile. Pedunculated includes a stalk or a neck and sort of hangs out into the lumen of the colon. You'll see a picture of that in a moment. Now, the more important histologic point as far as the risk to the patient has nothing really to do with either of these, but rather whether it's adenomatous, that is, that's tissue that's derived from a gland and therefore is undergoing increased cell replication through mitosis and is therefore more prone to developing into cancer? Or is it hyperplastic? It's just irritated tissue and it's just grown out like a callus into the lumen of the colon. These are very rarely a problem. Now, adenomatous polyps, as their neoplasms or growth of new tissue, they're found in the neoplasm category, the benign neoplasm section in ICD-10. And these are designated by their location in the colon: ascending, transverse, descending, sigmoid, and rectum. So with some good specificity, and happy to report that specificity is usually given on the colonoscopy report. Conversely, hyperplastic polyps are not neoplasms, so they're found in the gastrointestinal system, K63.5, and without a location. So even a hyperplastic polyp given with a location can only be coded to this one code, polyp of colon. Unfortunately, the not otherwise specified colon polyp falls under the hyperplastic, and that's again non-neoplastic, so not by location. There's a great bunch of coding clinics in 2017 first quarter that address a few of these issues. So as again, the risk of adenomatous polyps is them turning into cancer, and I was told by a gastroenterologist that eventually, and I think by eventually means over decades and decades, all adenomas will turn into cancer, and that's why they remove them all. Cancer coding in the colon comes down to whether it is primary, which it usually is, or secondary, which would be rare but can happen. There's a single code for a secondary, but nonetheless, the specificity of location for colon malignancies is even more specific than adenomatous polyps. And as you can see, all the parts and digits there. There's one interesting quirk here is the overlapping sites, wherein a patient may have a colon cancer involving the hepatic flexure and the transverse colon overlapping those two sites. And unfortunately, rather than coding both of those, we are guided by this ICD-10 coding guideline 1C2 to just use this single overlapping site, which loses the location specificity, but them's the rules. I don't make them, I just tell you how to follow them. And here's what colon cancer might look like. This is actually a digital photo, not a clinical photo, but you can just look at this and tell that is not right tissue right there. It can ultimately grow to involve this colon circumferentially, leaving on barium enema something that looks like an apple core constriction in the colon. And then in a surgical standpoint, you can see that there's a colon cancer inside and on the back side of this causing this stricture right here. So this colon looks a little bit distended. That's probably what's going on. There's a stricture. This would need to be resected out clearly for that patient's benefit. Now onto IBD, and I've made this D bold, so we'll know this is inflammatory bowel disease, not to be confused with IBS, irritable bowel syndrome. That's just one of those little initialisms that you could kind of glance at and see, and if you're fast fingers with your encoder, go to IBS when what you meant is IBD. Completely different condition, much more severe from a histologic standpoint, demands much more intervention. There are two main families of IBD, and there's a couple of other versions which you can look up in ICD-10, but mostly we're dealing with Crohn's disease or ulcerative colitis. Ulcerative colitis you'll find in the K51 neighborhood, and these are designated by region in the colon, the rectum, or both, and whether there are any complications. So having none of these stated, there is a not otherwise specified ulcerative colitis code by the region. And there are specialized specific codes for having an abscess, fistula, obstruction, or rectal bleeding. And its close cousin Crohn's disease is regional enteritis because it can involve the colon and or the small intestine. So it is coded by region, colon, and or small intestine, but with the same choices of complications that you'll see there. And here's what Crohn's disease might look like on a colonoscopy. These highly inflamed, mottled, hyperemic capillaries at the surface of the mucosa. There's a resected part of colon. And the risk for both of these is not just the pain, the diarrhea, and inflammation that these patients suffer, but that the rapid cell turnover in that mucosa makes it also more prone to development of neoplasms and malignancies too. So many times patients with these need careful monitoring with colonoscopies. Speaking of colonoscopies, let's look into some of those. There are many different varieties and modalities of colonoscopy. which I won't enumerate them all here. You can see them plainly in your CPT manual. We'll use as the sort of the cornerstone the diagnostic colonoscopy 45378, which is what you might see here. See that? Nice and clean, colon lumen, no polyps, nothing weird going on, which is great. There are many other modalities: cold biopsies, hot biopsy, forceps, ablations, snares are just some of a few of the many that there are. The main divisions of colonoscopies, and you'll find these segregated out in the CPT manual, are through the anus and through a stoma. Now, what do you do with multiple modalities used for one, let's say, one polypectomy? Let's take this pedunculated polyp. You'll see here's the body of the polyp. Here's the pedicle from which it grows, with a snare around it. If you're like me, coding colonoscopies, you kind of tend to think of the procedure as the instruments involved, and you see the hot biopsy forceps going in, the snare going in, and the APC coagulator going in. But just one thing to remember is it's still a polypectomy. So just as with an appendectomy, when one surgeon might use vicryl to close and the other one uses gut. One might use Coker clamps to isolate the appendix, and another one might use hemostats. Those are just different instruments to accomplish the same thing. Well, polypectomy is no different. Just using different instruments on the same polyp is still a polypectomy, as long as it's one polyp. Conversely, if there's different modalities used at different sites on different polyps, well, then you've got multiple polypectomies, and you can confidently code each of the different modalities with your 59 or XS modifier to indicate it's a separate site, separate lesion, okay? But this polyp removed with a snare, and then further, let's say, biopsy with a cold biopsy forceps, and finished off with a plasma coagulator, only one of those modalities can count as the polypectomy. And it's not hard to look up the work reviews. The reimbursement is either can be looked up by dollar value, or they all fall under the same APC, so that part doesn't matter. But it's commonly accessible, the sort of hierarchy of modalities that you can use, and it's, in a nutshell, as I last checked, 2018 was hot forceps followed by snare followed by biopsy. Excuse me. Generic ablation of lesion is lower, but don't trust me on that. Look it up, as these things tend to change. Here's a specific example that kind of caused a little head scratching, and hopefully I can help you work through it too. It's the endoscopic mucosal resection of a polyp, or EMR, versus the old school approach, which we're mostly acquainted with coding as an injection and snare, in a nutshell. So this 45381 EMR is a relatively new code in 2018. I mean, now it's 2018. It's been around a couple of years. And so when I first saw this, I said, boy, that sounds a lot like something I've coded a million times, the injection with snare. What makes it what it is? The CPT assistant of relevance indicates there are three elements to the endoscopic mucosal resection. The first part is logical, that's the injection. The third part is the snare resection. The middle part, the demarcation of lesion. What's that mean? So this would seem to be very carefully defined what it is, but they don't define what the demarcation of the lesion means. And if all these three elements are not present, we are not to code the EMR, but rather the component procedures, which falls back to the default approach that I'm used to, the injection and the snare. In any case, what both of those are likely to look like are this sessile polyp laying flat against the wall of the colon. It's injected with India ink, which tattoos not only the lesion, but also the underlying colonic wall, and can be seen from the outside of the colon in case it needs to be resected. Snare is reached around the polyp. Cautery is usually applied, but not always. And the polyp is burnt right off from its site, leaving a clean base. Tattooed colon wall. Here's down, looking right down on the site where it once was, and it would look similar from the outside too, again, in case it needs to be resected. So I don't have a magic answer for you unless your endoscopist documents an EMR and that they demarcated the lesion, then this is your code safe with. If they simply go through the procedural steps of injecting and snaring, you're kind of stuck with this, using this combo. But look out for additional guidance that might come along too. Good old screening colonoscopies. We'll all need one around 50, and they save a lot of lives and a lot of misery. But coding them can be kind of a hassle, because how they're coded determines how they're paid and whether the patient is on the hook or not. And we as coders can have a lot of influence on whether these things get billed and paid correctly or cause a great deal of headache for patients. The one main rule as of this year as to how far the scope must be placed is to the cecum now. It was previously to the splenic flexure, but now all the way to the cecum, which makes sense because colon cancers can occur all the way in there. Now, there are many different ways to capture screening colonoscopies. Well, namely 4 as I see it. There's G0121, the HCPCS code for low risk, and certainly usable for Medicare, and G0105, high risk, is the HCPCS. Now, in my experience, most payers actually accept these as well, and this is preferred because it's very precise, tells the story, and further delineates whether it's high or low risk, versus using the diagnostic colonoscopy code 45378 with one of 2 modifiers. Let me tell you how that works. The CMS or HCPCS modifier is PT, and that is specific for preventative treatment, specifically colonoscopy, a screening colonoscopy. That's the only code that, well, the only family of codes that this can be used on because it's just for colonoscopies. And that's your next best get. If you have a payer that doesn't accept either of these G HCPCS codes, this is your next best choice. The third best choice, in my experience, is the diagnostic colonoscopy code 45378 with a 3.3 modifier. It's a CPT modifier, and that indicates a generic preventative treatment for anything. Can include mammography and any number of services that should be paid by the insurance. Most insurances under Obamacare, 100% by the insurance. The patient is not on the hook. So you can see in the absence of any one of these modifiers, the patient may be responsible for paying for that colonoscopy. Now, it goes without saying, if the patient has what I think of as a diagnostic to a therapeutic colonoscopy, for example, started as a screening with every intention of being a screening and a polyp is found and it's removed by, say, biopsy forceps, you choose the colonoscopy with cold biopsy forceps with a modifier, ideally PT, or if the payer demands 33, to say, hey, we started this as screening, it just turned into the therapeutic, not the patient's fault. Incidentally, a colonoscopy done for any symptom or finding isn't a screening colonoscopy. And I could scream from my soapbox for days on that, but I will refrain from that during this presentation. But a screening colonoscopy for rectal bleeding isn't a screening colonoscopy. So hammer your endoscopist about that if you have a problem, as you can tell I did. The indications for a high-risk colonoscopy here are a few. This is not an exhaustive list, but a diagnosis code that needs to go with to substantiate the frequency indications for the high risk of 2 years. Personal history of cancer, family history of cancer, personal history of adenomatous polyp. Remember, there's a difference between that history and a history of a generic polyp that will not satisfy the frequency indications for high risk. From a clinical standpoint, other conditions stated as being for high risk, like ulcerative colitis and Crohn's, adequately documented, should be coded, may need a note to the payer to indicate this is the high risk, even though there's no history of cancer. And this is an indication, or this is an illustration of that colonoscope going all the way to the cecum right there. So while talking about endoscopies, let's look into ileal pouches. Now there are a few different kinds of pouches which we'll go into, and then I'll give you a little bit of a lesson about how they're created. But first, the endoscopy part. So first of all, what is an ileal pouch? It's a reservoir created of multiple folds of the ileum, meant to just simply increase the caliber or diameter of the terminal ileum wherever it comes to the skin in the form of a stoma, or to the anus in the form of an ileoanal anastomosis. So many of us are familiar with the J pouch. There are variations of having a triple fold in the W pouch or double fold in the shape of an S pouch. But let's use the J pouch for illustration. This suture line here is strictly external and doesn't indicate that there's actually, if you follow this tube down, it would go down and then it would bend back upon itself. If you cut this J pouch in half, it would not look like a two-barreled or like a number 8. It would be a ring like this. So it would be just one wide open lumen. So that's one thing to consider. A couple of synonyms for the ileoanal pouch is the IPAA, ileal pouch anal anastomosis, or ileoanal pull-through. A variation of this same exact pouch formation, but that ends in a stoma, is a Koch pouch. Different codes for creating that, but not a different code for scoping it. One thing I would like to emphasize, these are not Hartmann pouches, which you'll see is simply a residual rectum and sigmoid colon. So Hartmann pouch is a different thing, comprised of a different tissue with a totally different intention. These are all continent pouches meant to store stool. A Hartmann pouch has nothing in it at all. So the function of these are continent reservoirs, and here's the approximate volume that they can hold, which allows patients with these procedures to use the restroom in a normal interval, more or less, rather than having to use a colostomy type bag or ileostomy type bag. So to scope the pouch, remember the way I described, this is just one large reservoir, so it's in effect a replacement for a rectum. So think of a pouchoscopy as just a limited scope that would just involve the rectum if that's what was there, but in this case it's a pouch. Now there's only two modalities, one is diagnostic and one is a biopsy. Being as this is not colonic tissue, it's not super prone to develop the likes of polyps, so you don't see the snare, the hot biopsy, and so forth, but it is prone to inflammation, as a lot of patients who have had a total colectomy have ulcerative colitis or regional enteritis, and this is, after all, intestinal tissue and can continue to develop that inflammation. And number two, ileum is not evolved to be a reservoir with chyme against it, that's the food substance, nonstop. Therefore, that can cause, the pH can cause inflammation, irritation. So having a biopsy of a pouch is not an uncommon procedure. Now, these codes go for whether that's a ileoanal anastomosis or a stomal. So that's a convenient for us. That's not broken into two branches like colonoscopies. Now, as far as those so-called pouchoscopies that go up to the creation of the pouch, but further up the ileum, this is where it gets a little bit more challenging. There are currently, as of 2018, no rules that I can find that designate this, but blending my coding and clinical experience, I'll make a couple of recommendations. I like to say that a pouchoscopy would go to about 30 centimeters in, the typical interval between this anastomosis and this anastomosis. So about that far. Anything beyond that, there you have a couple of options. So just like a proctoscopy, followed by, at the same time, a colonoscopy, we would only code the colonoscopy. So a further look up through the ileum could just count as an ileoscopy, 44380, and all of the respective modalities that go along with that, biopsy and so forth. One thing I did want to mention, this is not an enteroscopy. For example, 44376, that's upper GI stuff, okay? So that's through the stomach, the duodenum, and the ileum this way, not from the bottom up. Now, what if we have an ileoanal anastomosis, as depicted in this illustration, that is up through the pouch, even further up the ileum? There's not really a great recommendation. Now, functionally, we go past what's the rectum, and functionally, what would be the sigmoid. So you can consider a sigmoidoscopy, or the best possible outcome would be to use the unlisted, and if your facility allows, or your practice allows, create what we call an imputed code, which allows to take the billing info and the work RVUs associated with an actual code and apply it and bill it with the unlisted code. So you're telling the story honestly, but you're billing the actual technical expertise that was performed. You'll commonly encounter, prior to colostomy takedowns, the so-called colonoscopy and pouchoscopy. So remember how I emphasized these ileal pouches are not Hartmann pouches. So don't fall into the trap of seeing colonoscopy and pouchoscopy as what I just described. Now, fortunately, there are good references as to how to code this particular scenario. What we have here is an endoscopy through the colon, through a stoma, colostomy, usually to check out for strictures, inflammations, neoplasms, and so forth, after this partial resection has been done. And then a different scope through the anus up into the Hartmann pouch, which is just a blind colonic pouch, rectum, and a little bit of sigmoid right there. Now see here we have two scopes, two orifices. Thankfully, we can actually use two CPT codes for that, one for the colon and one for the sigmoid. And there's my proof and CPT assistant right there. So this is commonly done almost universally prior to a colostomy takedown, a procedure which I'll describe itself shortly. So now we're working back up to the original procedure, or procedures that would have led ultimately to the scopes that we just went over, colon resection. So there are two families of that, governed by the approach, open or laparoscopic. The next thing we need to know is what's the extent of the colon resection, whether it's partial or total. So hemicolectomy is partial, a segmental colectomy is partial, a total colectomy is a total colectomy, and that's all it is, and that's from usually terminal ileum to distal rectum right there, sometimes including the anus too, just depending on the case. Now, total colectomy, not as often done for malignancies, but for the inflammatory bowel diseases or familial risks, high risks of polytomatosis, which can develop into cancer. So the risk of cancer or colon cancer is so high, sometimes the better option is just to remove the whole colon. And then the final element to coding a colon resection is what is the terminus, or what is the end? What's done with the end of that tube, the alimentary tract, to continue to allow the food to pass through it. They can be anastomosed back together, the two pieces of the colon. It can be terminated at the skin by a colon if it's a partial colectomy, or by a terminal ileum if it's a total colectomy too. So here's one example you see in the picture here is a removal of the splenic flexure of the colon and then reanastomosis of this end with this end. You have 44140 colectomy partial with anastomosis. You can see these are all versions of partial colectomies for CPT purposes that would all be coded under the partial, but would be different in PCS. Now, colostomies are commonly done with a colon resection, and when done so, they're in the resection code. That makes it pretty easy for us to be done. But there are unique instances where the colostomy is done in an isolated state. For example, a diverting colostomy when there's some inflammatory condition distal to that, and the distal colon, for example, needs to catch a break to heal up for some reason. So we would divert the stool to a stoma, often temporarily. And there are two simple codes for that, whether done open or laparoscopically. In case you're ever curious what a surgeon means by they brooked or they performed brooking or maturing on a stoma, that's simply suturing in such a way that causes this puckering up of the mucosal tissue to form somewhat of a spout, which will fit inside the appliance better than just having a flat surface, which can involute and cause all kinds of problems and skin irritation. So what you see here are the brooking sutures, and that's named after the surgeon who designed that procedure in the 1950s. An ileostomy would be done, again, usually with a total colectomy when all that's left is ileum. So it would terminate an ileostomy. However, if it's a colon resection done, it will be built into that colon resection code. But there are, conversely, two separate standalone codes for usually, again, a diverting ileostomy when there isn't a resection, and that's easy to find. The ultimate goal is usually to reverse or take down a colostomy or ileostomy just to restore something like the normal anatomy and function for the patient's alimentary tract. And there are three main codes that you would use for a colostomy reversal or takedown. So 442620 for small or large intestine. And this mostly pertains to a diverting ileostomy or colostomy, where the stoma itself is simply excised with a small bit of skin surrounding it, and the side wall of the colon or ileum is just simply sutured together. So there's no removal of any substantial amount of colon or ileum tissue. So 44620 may be just what you need. What's more common is a resection needs to occur where the terminus of the ileum or colon here is actually cut back to fresh tissue, and then the distal part where it's going to be rejoined together, like the Hartmann pouch, also needs to be resected and then rejoined back together. So then we take one of two different twists, and essentially it's 44625 or 6, depending on whether it's a colorectal reanastomosis or other than colorectal, which could be probably ileal, ileocolic, could be jejunum, any other version that's not colorectal. So now I've finally worked up to the point where we're tying it all together with the colon resection and the pouch. So with a total colectomy, J pouch or W or S pouch is a great option. And when done all at once, in the current state of technology in 2018, there's only an open option. And as far as I know, that's technically all that can be done, but it could always change. So that's the kind of at-once colectomy with J pouch. Now, what if they're done in a staged fashion due to surgeon preference or improved outcomes or patient condition and so forth? There's a couple of ways to go. So first, the total colectomy with an ileostomy, which is a totally valid procedure, and it doesn't foresee there being a pouch at all. It's just an ordinary procedure to remove the colon, create an ileostomy, and there we have it. 44150 open or 44210 laparoscopic. The stoma is basically included in the total colectomy, so to speak. Now, the second stage, when the surgeon comes back, to then create the pouch. This is where it gets a little sticky, and there's no perfect code for this. Here are a couple of options that you would consider. 45397 laparoscopic, but this is a colonic reservoir. So this is actually a proctectomy, a partial colectomy, where the rest of the colon is pulled down and anastomosed to the anus with a pouch. It's a J-shaped pouch, but it's not ileum, it's colon. That's not what we're doing here with the ileal J pouch. So that's not perfect, but technically speaking, insofar as how the surgeon goes about doing this, that's pretty darn close. 45113 is open with an ileal pouch, but not laparoscopic. As I understand it, the preference is to do this laparoscopically. So that's technically quite different, even though the anatomical outcome is actually correct. So there's no laparoscopic ileal J pouch. I think the best option, if your facility or practice allows, is to create the so-called imputed code using the, what I recommend is the work RVUs and reimbursement for this code, and attach it to the unlisted, and go ahead with that. And more mundane procedures, hemorrhoidectomies, where there's a whole bunch of them in the range here. These are not all hemorrhoidectomy codes. There's some fissurectomies and excisions and stuff in there as well. But focusing on where the hemorrhoids are. Now, what we need to know to code hemorrhoids are, number one, if they're internal or external, remember it's where they originate from, not that they're just hanging outside the body. The number of columns, and the main division here is, remember you can have up to 3. The main division is whether it's 1 or 2 or more, so 2 or 3. And then what's the modality being done? Excision, ligation with rubber bands or other forms. And there are a couple of others in there, all kind of right in the same neighborhood in CPT, and happily usually documented quite closely to the way CPT describes. Also, whether there's thrombosed, is there special CPT codes for a thrombosed hemorrhoidectomy or incision of a thrombosed hemorrhoid? So be sure to look for that condition. Something a little bit more likely to see in the ER or after an ER visit, rather than just the kind of routine elective hemorrhoidectomy, thrombosed. And then there are a few variations with a fissurectomy and fistulotomy towards the end of the CPT section that includes the hemorrhoidectomies too. So be vigilant for the documentation of those. Be sure you pick the right code. Now, they're not all scenarios covered, even though there's a bunch of different variations. For example, the excision of a single external hemorrhoid isn't the code for it. There's excision of a hemorrhoidal tag, which would be your choice, but if you work closely enough with your surgeons, be sure that they know that doesn't exist. So if they do that, be sure that they're not talking about a hemorrhoidal tag rather than an active hemorrhoid currently. Here's a new technology that's got a new technology CPT code, transanal hemorrhoidal dearterialization, THD. And I think this is a really clever solution to a hemorrhoidectomy because it doesn't involve excising off any codes or excising off any tissue. It just removes the supplying the arterial blood supply from the offending hemorrhoidal plexus. And here's how it works. We've got this proprietary special probe anoscope that's inserted that's got an ultrasound transducer here that can see the artery, and it's got a suturing mechanism that has sort of a twist function to it that's looped around the superior rectal artery here and ligates it off. Now remember, the rectum has tons of other arterial supply, so it can kind of do without this one if this is the artery that's feeding the internal hemorrhoid plexus here, okay? So first the artery is ligated, and then oftentimes the mucosa is plicated or wrapped up in suture and sort of wrinkled and folded together so it can't further distend. Now that so-called mucoplexy, there is a mucoplexy code, but we don't use it in this case. That's all included in the THD. And the one other thing to remember, in the unlikely event that other hemorrhoidectomy modalities are used, like an excision or ligation, as of the last I checked, this 0249T bundles into all of them, which seems kind of backwards because this seems like the more advanced procedure. But nonetheless, my recommendation would probably be just to leave off the other hemorrhoidectomy code and use this one, assuming the payer accepts it. As far as in real life, I haven't seen a surgeon do a THD with another procedure, but I'm not saying it's impossible. And then abscess drainage, coming back around, here's some CPT codes for an IND of a perianal or anal, superficial. So that's kind of right under the mucous membrane, right there, outside the sphincters. You've got your perirectal, ischiorectal, which is outside the sphincters, like here, and perirectal here under the mucosal. And then another variation, and there are a couple more I didn't list here, but intramural would be in the wall of the rectum here. Intramuscular could be inside any of the actual sphincter substance, and submucosal also in the rectum, but just under the mucosa, but not quite into the wall of the colon too. In this case, we look very carefully for precise documentation of the location. Don't be shy to query if you need to get that one nailed down. And then fistula treatments. Fistulas are passageways that develop between two spaces or potential spaces that allow passage of fluid. And the perirectal and perianal fistulas are some of the more common that can occur. Oftentimes in inflammatory bowel diseases, this can be the result. And these blue lines kind of indicate some of the usual passageways of fistulas through the perianal and perirectal tissue. Here's one of the CPT codes for treatment of a fistula, ischiorectal intramural, with removal of the fistula. So fistulotomy, just cutting out that diseased tissue and with it the fistula passageway. Now, less aggressive and preferable treatment is placement of a ceton, which is seems like kind of a weird thing to do, but by probing through this fistula, this is looks like an intersphincteric, at least partially intersphincteric, a piece of non-absorbable suture is placed and tied with a certain amount of delicate tension, so that the body tends to allow itself to be cut through, and it tends to expel the thread like a foreign body, leaving healing tissue behind it. So it takes the fistula from being actually in the tissue, and it gradually migrates up to the mucous membrane, and then the ceton thread just pops out and heals nicely. So that is the end of this colorectal surgery webinar. Hope that's been okay for you. And it's been Ed O'Byrne with HRG. Go back to the webpage to look for your CEU test and credits. Good luck on that, and give me a shout if you need anything. We'll see you around next time.